All right, I think we're going to get started because there's a lot of material to cover. And so I'm Joel Kennedy. So I'm actually going to just form as an introduction tonight and go through the agenda and objectives. And then I'm going to hand over to Dr. Rebecca Ray and Dr. Brad Wiggers, who will do the presentation. So just a couple of things. If you're on the phone, *6 to mute. If you're on the computer, please just press the little mute button. We'll get you to put your hand up if you have questions. I will interrupt the two speakers for questions, hopefully in a timely manner, so that we can be interactive as possible. And of course, you may also ask questions in the chat box. So feel free to type there, and we will try and get through them all. And then if there's some questions that aren't really in the setting of what's being talked about, we'll go through them at the end. That's okay. So Cecilia is going to run the slideshow. So there's a couple people that record. Cecilia Craig is our project guru who helps keep us organized. Tracy Bromell is also one of our leads, and she's on here. I'm going to put them on the spot and make them show their cameras and say hi to everybody, because these are the people who organize us. And Kirsten Burgomaster is also our VP in charge of all this. So if Cecilia and Tracy can go on camera, I'd like them to say hi. Because these are the people behind the scenes that make this all work. There's Cecilia.
Hi, everybody. Thank you so much for being here.
I'm going to pay for doing this.
Hi, everybody.
So. All right. So thank you for coming on. So as you know, this is about prescribing Paxlovid. About a couple of weeks ago, OH released Paxlovid into community pharmacies. And so it has been a mass education project from the Ontario
70 people are on.
Ontario College of Family Physicians, as well as multiple agencies. And so we thought we'd bring everybody from the Central East together to talk about Paxlovid from two people who I would consider experts in Dr. Wiggers and Dr. Ray. And so we'll do that. So next slide, please, Cecilia. So I mentioned these. So Dr. Wiggers is an infectious disease specialist and the medical director of our therapeutics clinic. And Dr. Rebecca Ray is a family physician in Port Perry, and she has been a co-chair, co-lead of the Durham COVID Assessment Centers with myself, and a vaccine hat, Port Perry Hospital site lead, and I can go on and on. So a number of roles, and Brad was also the medical director of the vaccine clinic at UOIT. So these two come with a lot of credentials, a lot of different knowledge base that we think is very useful for this discussion. And as you can see, they have much better pictures than I do. So I'm going to jump right in, and I believe we'll go over the agenda. So Paxlovid, we're going to talk about how it works, who we should be targeting and how to prescribe it properly. There'll be some tools, some pearls for remdesivir, and then we're going to talk about a new drug that not many people know about, but EvieShell, which is for prevention in immunosuppressed, and then we'll go through a Q&A. And objective-wise, again, to identify those who are eligible for treatment, as per the Ministry of Health, as well as the Ontario Science Table. As you know, there's a slight difference in the two. Dr. Wiggers will go over treatment options, as well as Dr. Ray. We'll understand the pharmaceutical components and some common reactions to be aware of as we prescribe to the general public, and then what's available for you for supports, which is probably one of the most important parts of this talk. And I think with that, I am going to hand over to Dr. Wiggers to start the education.
Great, thanks, Joel. Cecilia, next slide. Perfect. All right, so we'll start with the drug itself. So Paxlovid is actually two medications co-packaged together. So nirmatrelvir as well as ritonavir. Nirmatrelvir is the active drug against SARS-CoV-2, and it acts as a protease inhibitor, essentially blocking the protease and ultimately blocking viral replication. Ritonavir is a drug that's been around for quite a while. You may remember it in the context of HIV regimens. In those regimens, and really here as well, it's mainly being used as a booster. So it's an inhibitor of CYP3A4, and by doing that, it allows better levels of nirmatrelvir so that it can be dosed just twice a day and 2 tablets twice a day. But because of this interaction, leads to a lot of challenges with some of the chronic medications, which we'll get into. As you can see on the right, the medication actually comes in a blister pack, and the dosing intervals are packaged together. So the standard dosing is 2 of the pink tablets, 1 of the white tablets. Someone stole the screen.
Brad, I'm just gonna pause you.
Figure that. So
Brad, I'm
the
just gonna
standard
pause you.
dosing is.
Oh, sorry, Brad, 1 second. Marlene, your hand is up. Is there an issue you want us to help you with right away, or?
No, sorry.
Oh, okay, sorry. Sorry, Dr. Wiggers.
No problem. So yes, the standard dosing is 2 of the pink tablets, which are nirmatrelvir, 1 of the white tablets, so 3 total tablets twice a day for 5 days. For people with moderate renal dysfunction, eGFR is 30 to 60. It's a dose reduction of the nirmatrelvir. So the renal impairment doesn't impact ritonavir, it's hepatically metabolized. So the renal adjustment there is that 1 of the nirmatrelvir tablets is removed from each of the dosing intervals. This should be done at the pharmacy. So it ends up being 2 tablets twice a day for 5 days. The medication can be taken with or without food. The key thing, though, is it can't be crushed or chewed. So people with enteral tubes or swallowing difficulties, this might present a problem. So it's an expensive medication. I think it's about $750 for the 5-day course, but it's free to anyone who's living in Ontario. There's no charge through the pharmacy, and even if they don't have a health card living in Ontario, that they can access the medication. Next slide. So the data that we have around Paxlovid is that it reduces the hospitalization and mortality in people who are at high risk. We'll show a little bit more of those data on the next slide. As far as whether it will benefit in general, as far as the speed of recovery or the severity of symptoms, mechanistically, you would think that if it's reducing the amount of virus, it's going to shorten the course of illness. This hasn't really been borne out in the data to this point. You can see the quoted text here from the EPIC-SR study, which is actually not published and peer-reviewed at this point, but one of their endpoints was looking at self-reported sustained alleviation of symptoms for 4 consecutive days, and it did not meet that endpoint compared to placebo. But anecdotally, we've heard people feeling very quickly better on this medication, with many people recovering on their own. Who knows if that's really a medication effect, but it has been shown to prevent progression to severe disease. By reducing the viral load, it might reduce transmission as well. It doesn't have any impact on how long people need to self-isolate for. That's a common question. And additionally, any impacts on long COVID, are mainly essentially speculative at this point. There's no data to suggest that it would, reduce the risk of that. It is generally a safe medication aside from drug interactions. And again, we'll get into that in detail later. Next slide. So this is the main study that's been published to this point on Paxlovid. So this is the EPIC-HR population. So this is the high-risk group, and I mentioned there's the SR study that's yet to be published. So this was for symptomatic outpatients not requiring oxygen with 5 or fewer days of symptoms. Importantly, so this was a strictly unvaccinated population, and they needed to have at least 1 risk factor for severe disease. And as you can see with the breakdown, that the median age was 46. Only about 20% had more than 1 comorbidity, so likely there was not a lot of polypharmacy going on, and very few were immunosuppressed. So if we think through who we are treating, this isn't overly representative of the individuals that we're offering Paxlovid to, and that tends to be referred for consideration, even though the populations we're seeing are also high risk. But so there certainly would be extrapolating benefits from this study to other high-risk groups, but as far as sort of the safety and the side effects and the tolerability, I think that the populations we're seeing often have a lot more challenges with that, with a lot of chronic meds that they may be taking in particular. So as far as the outcomes of this study, so in this high-risk unvaccinated population, there was a reduction of the risk of hospitalization or death with a relative risk reduction of 88%. A number needed to treat of 18 to prevent one of these episodes. And they did, as sort of a secondary portion of their analysis, also show that sort of mechanistically that this was reducing the viral load when remeasured on day 5. Next slide. So when we talk about benefits, it really does matter what the baseline risk of the population that we're treating is. And so, if we have a population, for instance, with a baseline risk of hospitalization of 5%, then we're looking at the number needed to treat with this medication of about 23 to prevent 1 hospitalization. But if you begin offering this much more broadly in the population to those with much lower risk, that effect gets diluted. And so with someone with a 1% risk, it's going down to a number needed to treat of 114. And with this being a limited resource and very expensive medication, as far as sort of the ministry costs of it, this is an important thing to be taking into account. Next slide. So as far as the various medications that have been studied in the outpatient setting, so this is more or less the most effective and certainly the most accessible and effective of the drugs that we have. Previously, we would be using sotrovimab, a monoclonal antibody, as our second line, which essentially had this similar efficacy, but with the Omicron variant and subvariants. This is not effective against these strains, so we're no longer using sotrovimab for treatment. And so really the only other option which is as effective as Paxlovid is remdesivir. But as you can see, it's strictly intravenous medication. It requires 3 daily dosing, which is quite a challenge in the outpatient setting. We'll speak a little bit more to that towards the end, but really the options are quite limited. The other things we would typically offer would be something like an inhaled budesonide, perhaps fluvoxamine as well. Next slide. Okay, so as far as risk assessments, so the Ontario Science Table has really been an excellent resource throughout the pandemic as far as guiding treatment options. Early on, it was really restricted to inpatient treatments because that's all that we had, but more recently, some resources for risk assessment and guidance in the outpatient setting as well. So this is a bit of a busy table if you haven't seen this before, but as you kind of familiarize yourself with it, it is a really useful resource as far as risk stratifying. And essentially what they were looking at was the data on hospitalization in vaccinated populations, specifically with some data through the early parts of the Omicron wave. And looking to see which portions of our population have at least a 5% risk of being hospitalized in that context. And so the important variables are the number of vaccine doses, the age of the patient, medical comorbidities, as well as whether or not they're immunocompromised. And I'm certainly not going to have you able to memorize this table, by the end of this talk. But I think the important things to point out is there's sort of a gradient effect. So the more vaccine doses they have, the lower the risk. The increasing age is an increased risk. For those who are immunocompromised, really, regardless of their age, regardless of their vaccine status, they are in the high-risk group and would be eligible for treatment. And then I think the other important way to frame this, because the majority of the people that we're seeing are triple vaccinated, at least, if not quadruple by now, is that for those who are triple vaccinated, those who would be considered in the high-risk group are really just those who are either immunocompromised or who are over the age of 70 and with multiple medical risk factors. So through our clinic at the Ajax Pickering Hospital, we often get referrals for individuals aged 45 to 65, triple vaccinated with a few medical risk factors. Really, these are not high-risk individuals and generally would not be considered for therapy. But the age is not by no means sort of a very stringent criteria. If there is a very complex individual under 70 who through clinical judgment we feel to be high risk, we would certainly treat. But the majority, even with diabetes, obesity, blood pressure, common medical comorbidities would be well protected with 3 doses of the vaccine and not really benefit from treatment. And this is some of the data that helped inform this sort of risk stratification, as this is from BC in the early parts of the Omicron wave, looking at hospitalization risk, again, sort of stratifying based on number of vaccine doses as well as age and number of comorbidities. And you can see, essentially just important to see the sort of gradient effect, increasing risk with age, decreasing risk with number of vaccine doses. And if you look in the bottom right corner, you can see that for a 80+ individual with 3 medical risks, despite 3 vaccine doses, there is over 10% risk in that population. So certainly, despite vaccines, there are some groups who are still vulnerable. Next slide. Okay, and so with the rollout of community pharmacies carrying Paxlovid, there also came an announcement through Ontario Health that included a slightly different sort of itemized list of individuals considered to be at high risk. And I think that the focus when this list came out really came to be on sort of these bullet points of who these groups are. And so you can see it's overlaps, but a little bit broader than the science tables guidance. So immunocompromised, again. Here it says everyone over the age of 70, regardless of health status or vaccine status. Individuals over the age of 60 if they haven't had at least 3 doses of the vaccine, or individuals 18 plus who have less than 3 doses or any medical risk factor. So a 20-year-old with 2 vaccine doses and well-controlled asthma technically falls into this risk group. But I think what's important here is not so much the sort of exact definitions of these groups, but that this was really meant to be a guide and to say who may benefit, who may be eligible, to sort of point these individuals to coming in and getting assessed, but not necessarily to treat every single individual who fits into one of these bullet points. And so if you see in the text above, I think Cecilia, if you can advance one slide. So this criteria outline who may be at higher risk, use clinical judgment determining whether treatment, is appropriate. So, there's eligibility and then, there's potential for benefit. And so I think it's important to understand that there, are nuances here and to assess the pros and the cons of this treatment. Next slide. Okay, and so in general, then, as we're assessing these individuals through our the COVID therapeutics clinic, for the most part, we are continuing to use the science table framework. Again, we're not overly dogmatic on this, and there is clinical judgments, but I think this really is the most evidence-informed resource that we have, and important, useful in discussions with patients around this as well. Next slide. Okay, so I just wanted to linger on the definition of immunocompromised just for a moment, because this is one of the criteria where, regardless of age, regardless of vaccine status, if they're immunocompromised, they do qualify for treatment. Some of the definitions are quite broad, and definitely there's some individuals, patients who consider themselves to be immunocompromised, where really they don't meet the strict definitions that are outlined here. So one of the fairly broad definitions is anyone who's on active treatments for a solid tumor. Really in this population, the risk is around those who are on cytotoxic chemotherapies. As far as specific risk of severe COVID with some of these newer targeted agents or immunotherapies, it's not really clear that they necessarily will increase hospitalization risk, but in general, we would still offer in these contexts. But for individuals who have prior cancer, who are on surveillance, or who are on things like tamoxifen or some of the hormonal therapies for prostate cancer, really that's not an immunocompromising condition. active treatment for hematologic malignancies, as well as individuals who are under surveillance for things like CLL or low-grade lymphomas would be considered. Asplenia is not specifically addressed. Really, again, it is an immunocompromising condition, but not really a specific arm of the immune system that really impacts COVID risk or response to vaccine for COVID. In general, if these patients are medically complex for other reasons, we have been offering, but that one is a bit of a gray area. Solid organ transplant recipients, bone marrow transplants, those with moderate or severe congenital immunodeficiencies, advanced or untreated HIV, so not individuals who are taking their medications with a suppressed viral load, but those with low CD4 count and uncontrolled infection, which is thankfully quite low these days. Various immunosuppressive biologics are included. Essentially, all the immunosuppressive biologics are included, but really, again, there's sort of a spectrum here as far as actual risk. The things like the anti-TNF alphas, anti-IL-17, IL-23, really, probably don't increase the risk of severe COVID all that much. But again, they're listed, and we would discuss the nuances, but offer if the patients are interested in treatment. The definition of high-dose steroids is prednisone over 20 milligrams per day for 2 weeks. Things like Entocort for colitis or inhaled steroids don't count as immunocompromising. And then the majority of the other DMARDs or immunosuppressive agents are within the definition. Things though like Plaquenil, as a monotherapy for mild lupus or Copaxone, really wouldn't be considered immunosuppressive, however. Next slide. Okay, so on to some of the challenges with Paxlovid. So although it's free to everyone in Ontario, it is not a cheap medication. A lot of expense for the stockpile that we've purchased through the ministry. It's not readily available, so there is a big list of pharmacies that carry this medication, but not all of them do. And we've run into issues where they were early on only able to get a few doses per day, and we'd prescribe at them in the morning, and they'd be out in the afternoon. So that's been a bit of a challenge, but I've seen it getting better as the weeks have gone on. It's got a lot of drug interactions, which really means it not being so simple or straightforward to prescribe. And it's not free from side effects. So really, as far as dangerous issues, it boils down to the drug interactions. As far as side effects, the common things that we see are really intestinal symptoms. So a metallic taste in the mouth is very common, diarrhea, nausea. In the studies, these were reported around 5–10%. I'd say we're probably seeing that a bit more in sort of an older population that we're treating. And again, with the trial really not having many people, with multiple comorbidities, a fairly young population, the side effects that come out of some of the minor drug interactions or drug adjustments that you make are really not going to be all that captured in that data and can really become a problem. Next slide. So as far as the drug interactions, it's unfortunately a really long list. There's a few helpful resources to navigate this. So this is the table from the Ontario Science Table. It's a really helpful visual resource. It's not exhaustive, so it's missing some common things like domperidone, fesoterodine, ivabradine, which are strict contraindications. So if you're not seeing a medication on this list, don't assume that it's safe. It basically will give you a green check mark if you're okay to co-prescribe. The yellow and the red should be either dose adjusted or held or replaced with another medication. And then there's some that are a black triangle or a black and white triangle, which just can't be co-administered for a few different reasons. And in this document, there's more pages that actually go into some specifics of the adjustments that they would suggest to make, like whether it's holding or reducing by 50%. So it is a useful kind of first pass as far as a quick resource for navigating some of this. Next slide. So some of the common interactions that we see that it's important just to kind of flag you as you're looking through a medication list. So statins are a big one. Those ones are pretty easy to just hold. calcium channel blockers, anticoagulants, antiplatelets, benzos, most of the prostate medications, domperidone. Often some things that people may not remember to mention on a first pass. So, for their inhalers. So Advair is really the big problem because of the interaction with salmeterol. If you're using something embedded in EMR looking for drug interactions, all of the inhaled steroids will flag as a problem. Those aren't actually an issue. That's really just for chronic use where you'd end up with more systemic absorption of the steroids. For this purpose, you can co-prescribe, and often people will need to stay on their chronic ones because of the symptoms, or you may prescribe new ones like budesonide as part of the acute treatment. For sleep meds or things that people are using as sleep meds, lots of interactions. And then with the pain meds, there's some that would be boosted, some that would have decreased efficacy. Next slide. So some of the most challenging interactions are the transplant medications, tacrolimus, cyclosporin. I don't play with those unless I've spoken with the transplant physician, so usually that requires a call. Warfarin is a bit unpredictable, so really you kind of need to know, what is their risk of bleeding, what are their recent INRs, what is the reason they're on the warfarin, is it going to be dangerous if they're out of their therapeutic range for a short time. The novel anticoagulants as well, and then with the antiplatelets, it's not so much knowing that there's an interaction, but understanding clinically, how important is it that they're remaining anticoagulated for this next week. And some of the cardiac medications, digoxin and diltiazem, and some of those are a bit challenging as far as adjusting doses. And when in doubt, really important to speak with a pharmacist to help with some of this, but I would encourage not to rely strictly on the community pharmacist, because a lot of this isn't just about knowing whether there's an interaction, but understanding the clinical context. Next slide. Okay, and I mentioned that there are some absolute contraindications. So essentially it boils down to either things that have a long half-life, and so even if you hold it, it's still going to be in the system and could be boosted. So a lot of the antiarrhythmics, including amiodarone, a few of the psychiatric medications like lorazepam, fentanyl patches. And then there are some things which are sort of either boosters or inhibitors themselves. And so once, if they're in the system, they've already affected metabolism in the liver, and they'll actually lead to nirmatrelvir being ineffective. So things like rifampin, dilantin would be the ones that fall into that group. Next slide. Okay, and I think I'm passing over to Becky.
Perfect. I get to do the fun stuff. So I get to do some tips and tools on Paxlovid prescribing and lead you through all great, there's a ton of great resources out there. Sometimes it's just trying to find where these resources are and how to put your finger on them. So I'll run through all of this, and I'm going to try to leave us enough time for questions because I imagine there will be many. So I created this little sort of how-to guide, tips for prescribing Paxlovid. So, I think one of the first things is identifying your high-risk patients, and you can do this ahead of time. So, run through your COVAX data that's coming to you. I'm not sure how often they're doing it, monthly, weekly, and where you'll know if your EMR has the ability to do this, run through a search for all of your over 70s unvaccinated, and consider emailing those patients and letting them know that if they do get COVID, they're a candidate for treatment and they should connect with you urgently so that you can review them and get them treated. Identified and treated quickly. The other thing to consider is if you do have high-risk patients and they have renal disease and they haven't had an EGFR done in the last 6 months, it's worth reviewing those patients too and ordering that creatinine for those patients so that, again, if they do get COVID and you're considering Paxlovid, you have an up-to-date EGFR for those patients. We're not doing, Dr. Wears will can comment on this if there's any need to comment further, but not every patient who gets Paxlovid needs to have an EGFR drawn or confirmed. If you've got an otherwise healthy, 72-year-old with no known history of chronic kidney disease who's unvaccinated, that would be very reasonable to just prescribe them Paxlovid without doing an EGFR. But it's your more complex patients with known chronic kidney disease or hypertension and diabetes that you're going to want an up-to-date EGFR. So identifying those patients, educating those patients so they know who they are and they know that they need to present for assessment within 5 days if they do develop symptoms. That's important. And then developing a strategy for confirming infections. So I put a star beside this one because right now the strategy that I think most of us are using is rapid antigen testing, and that's a fabulous strategy. The challenge is with rapid antigen testing, when the positivity rate gets below 5%, a positive rapid antigen test is currently, this might change. Currently, if the positivity rate is less than 5%, then a positive rapid antigen test is not considered enough to confirm the presence of COVID. So, that false positive rate becomes more of, right now when there's, a 16.5% positivity rate of COVID in the population, we're not worried about false positives. I mean, if you've got symptoms, and you've got a positive rapid, it's a slam dunk. But in early August, when there's no COVID at all, and you have somebody with symptoms and they haven't had any contacts and there's just, 0 cases in our community, then we're going to need more than a positive rapid antigen test. So that's when you're going to need a molecular-based test. So, developing a strategy for what you might do then. Currently, again, rapid antigens are perfect for us to use in primary care. Our COVID therapeutics clinic does have the ID Now machines, and we all have access to PCR testing. So you can have this patient PCR tested, so you could swab them and send it to your usual labs as long as you're getting it in a timely way. Confirming the timeline of infection. So for Paxlovid, the onset of symptoms has to be less than 5 days. I just put less than 7 days here because some patients will be a candidate for the IV infusion, and that is less than 7 days. Confirming patients want treatment. So just because we think a patient is a candidate, they might not want treatment and they might not consent to treatment. And certainly that has happened a lot with us at the COVID therapeutics. We receive referrals and these patients are great candidates for treatment, but they just prefer not to be treated for one reason or another. So being sure that you do discuss that with your patient. Or do they want treatment and do they consent to treatment? Referring the higher risk patients to the COVID therapeutics clinics. So, your pregnant patients who are unvaccinated, your immune compromised patients, if they're complicated, obviously your end-stage renal disease, your liver diseases, complex polypharmacy, anyone that you're uncomfortable with. We might be very comfortable prescribing for our 72-year-old unvaccinated with absolutely no comorbidities. That's the ideal patient for us to be prescribing. And certainly some of our family health teams in the region have pharmacists associated with them, or we have pharmacists in our communities that we can use and rely on, who can be a fabulous resource. But if you're uncomfortable, if you're unsure, that's exactly what our CTC is for. Phone a friend, and don't forget about follow-up. So after you've prescribed it, don't just shut your computer down and forget about the patient. Think about the follow-up. So at our CTC, we initially did our follow-up calls at 3 days and 5 days. Referrals are increasing. It's harder to do that. But if you do have even a nurse or a reception staff in your practice and you're able to just send them a delayed email to check in on that patient at day 3 and day 5, that way anyone who's having trouble, that'll be flagged and get back to you and those patients won't get missed. And the COVID at Home program is very much alive and well in Durham Region, and it's a really great resource. So that is run by our Central East LHIN, and any high-risk patients can be referred to that program. And basically, they get an oximeter and they get some ongoing follow-up from a nurse to identify how they're doing and how they're progressing. Next slide, please. So starting Paxlovid, we've gone through this. So, you want to get them patients identified within that first 5 days from the onset of symptoms. So from day 0 to day 5. So actually you've got 6 days. because the first day of symptoms is considered day 0, and then you'll start your treatment. And so the treatment phase is 5 days for actively taking those pills from the blister pack, but it's a 7-day phase because there is that 2-day delay at the end before they will resume any medications that have been held and whatnot. So we look at that symptomatic phase and the treatment phase. Dr. Wiggers went through dosing. So dosing of Paxlovid is really, really straightforward. In fact, it comes in a blister pack with the 2 pink pills and the 1 white pill. And if someone needs renal dosing, then they actually just take 1 of each. So it's 1 and 1. And for EGFRs less than 30, so as per the Ontario Science Table, Paxlovid isn't recommended. But on the next slide, I think we've got some renal dosing guidelines that are coming out. So there are some guidelines that are in the works for patients with more advanced renal dysfunction. And certainly you might start to see some of your patients who are followed by nephrology with very low EGFRs being prescribed Paxlovid. Don't be alarmed. This might not be something you do yourself right off the hop, but certainly there is evolving guidance around using Paxlovid for very end-stage renal disease. And again, a lot of this is the risk benefit. And as we use it in real practice, more information comes out, and we're able to get real-time data on how it's working and efficacy and safety too. I mean, the nephrologist can follow these patients pretty closely. So just some practical tips. So if your patient doesn't want it because they're worried about the cost, this is free for all people in Ontario. One of the challenges with Paxlovid is that the pills cannot be crushed. So this is a huge barrier, for example, in long-term care, where there's dysphagia and medications are needing to be crushed in applesauce and things like that. These pills cannot be crushed, so that is one of the big barriers for this. They're decent size. They're not huge, but the size of the tablets might be a barrier to some patients. They can be taken with or without food. And as Dr. Wiggers had said, the main side effects really are this poor taste or alteration of taste, and then GI side effects. So diarrhea is very common. I think 5% so 1 in 20 people will experience the abnormal taste and the diarrhea. For renal dosing, you could ask your local pharmacist to remove the second pink tablet to make that easy. So if you're worried about a patient who has an EGFR between 30 and 60, and maybe they aren't as reliable, or maybe they have a little bit of memory impairment or cognitive impairment, you could always ask the pharmacist to pop out the second pink tablet just to improve the reliability and of the medication. Pharmacists can also take the pills out of this blister pack and add it to a patient's own blister pack. So that would be something that the pharmacist can do as well. Of course, there could potentially be a charge for all of this. The pharmacist can't bill for Paxlovid itself, but they certainly are allowed to bill for any services that they provide. So just a few more prescribing tips. So again, just reiterating, the patients they might be eligible, but are they likely to benefit from treatment? And when you're approaching patients, actually approaching from that perspective. So you might get a 40-year-old with hypertension who is very insistent that they want Paxlovid. And one of the things that you can talk to patients about is, okay, you're technically eligible based on the Ministry of Health if there are 0 doses of vaccine and hypertension, but is it going to benefit you, is the question. And you know, there are drug interactions and the adverse side effects and things like that. So that we're really looking at who's going to benefit the most from this, and reinforcing vaccination. You know, a patient who might have risk factors, who is fully vaccinated with 4 doses and has multiple complex drug interactions, we might be talking about the risk benefit ratio with that type of patient. And, you know, if they've gotten the benefits of vaccine. And so sure, you know, these patients who are super high risk with more than 5% risk of hospitalization, they're the ones who will benefit the most. But if there is a ton of drug interactions, or if they just can't take it because they have an absolute contraindication like amiodarone, then just reinforcing that vaccination was the right, they did the right thing by getting their 4 doses or 5 doses of vaccine, and then following them closely. Remembering the pharmacist is your friend. So working with your pharmacist, helping your pharmacist. So, you know, if you write a prescription for Paxlovid, maybe add your cell number on there, maybe call the pharmacy and give them their number just in case there's any questions, so that they're not trying to get a hold of you, because it's so time sensitive. If there's a question about what medication to hold or what to do with the medication, you want your pharmacist to be able to get a hold of you so that the patient can access the treatment in the timely way. And then using the Paxlovid prescription. So on the next slide, there is a great tool. So this is awesome. The eHealth Center of Excellence has developed this tool. It's a Paxlovid prescription. You can go to eHealthCenterofExcellence.ca and download this download this right into your EMR. So you only have to do it if you're in a practice like I am with 35 other physicians. You only need 1 copy of this downloaded into your EMR, and everybody has access to it. I think it's available for Accuro, Oscar, and PS Suite right now. But this is a really great tool. You can also go to covidinfo.ca and eHealthCenterofExcellence.ca and get a hard copy. And I would absolutely recommend, if you're going to prescribe Paxlovid, that you use this, because this is a great way to communicate with your pharmacy. So don't just write Paxlovid, you know, BID times 5 days and send the patient off. You want to let the pharmacist know why you're prescribing it, you know, what medications are going to need to be held, what the patient's EGFR is, so that they don't have to go and look that up themselves. Many pharmacists have access to that now through OLIS, but, you know, this is a really great tool. Next slide. This is just how you get the tool. So this is just showing we've got PS, Oscar, and Accuro, and a PDF version. Other great tools. So the Ontario Science Table, if you haven't been there, it's awesome. Go to their website. There's this article on what prescribers and pharmacists need to know. That's where Dr. Wiggers was pulling that drug interaction checker. So this is a really good tool. The Liverpool tool is a really fabulous online drug interaction tool with a specific COVID-19 drug interaction. So you can actually do that all online, put the patient's medications in, and it tells you what to do with the medications. So again, all of these tools aren't perfect, but they're great to have at your fingertips. This is the OST tool that I was talking about. If you haven't been to this website, so Mississauga Medical Arts Family Health Team has a really fabulous website. And if you go to covidinfo.ca and click on health professionals, there are a lot of really great tools. So they actually have a link to the Paxlovid prescription. They have a link to the guidelines. They have a link to patient information. They've actually got a link to the referral form for, Satruvimab, which we're not using anymore, and remdesivir. Really, it's a really great resource for healthcare providers, family docs, nurse practitioners, anyone who's needing it. A couple of tools for communicating with patients. So there's a patient information sheet that Ontario Health has developed. The Ontario College of Family Physicians has an adaptable script that you can use. Again, this is for talking to your patients about who might be candidates for Paxlovid and what they need to do if they get symptoms. There's also on the next page, Ontario Health, I'm not sure if it's the next slide, Cecilia. So Ontario Science Table And the Center for Effective Practice has a really great clinical guideline for primary care providers. We will give you all the links to all of these different tools in an email after we'll make this available. It will also make our slide deck available, and we're always happy for people to use our slide deck. If you're doing another presentation, you can go off, see one, do one, teach one, so you can hear us, and then you can go off and do a presentation and teach your colleagues. Please do that. Next slide. So Ontario Health, just like they've created a patient information, they also have created a document for healthcare providers around prescribing Paxlovid. So that's a really nice tool as well. And just some resources. A pharmacy tool. So they're on the Ministry of Health website, they have a link to an Excel spreadsheet with all of the pharmacies that are prescribing Paxlovid, all of the pharmacies that have Paxlovid available to them. So you can go on that link. There is also a link that we will share with someone really savvy, computer savvy, has actually created a map of pharmacies in the GTA and in Ontario generally with all of the pharmacies that have Paxlovid. And so it's a really cool tool that we'll share with you as well. Next slide. Confused, if you haven't been to this website, this is fabulous. This is a really great website to refer your patients to. It's called Confused About COVID, and it has been developed, I think, University of Toronto and I think the OCFP. I can't remember who developed it, but it's a really fabulous. And Hamilton, I think too, they have a hand in this. But this is a really great website. I think it's confusedaboutcovid.ca. And just a last reminder, so fourth doses. So, as we're talking about Paxlovid, remembering vaccine, like prevention is really the key, so we have treatment, but we don't want to forget about prevention. So I just put this in here to remind everyone, keep thinking about prevention, reminding your patients who are eligible for those fourth doses to get those fourth doses. Most beneficial for the very frail elderly. That's who's going to benefit the most, and your immune compromised patients, but really, anyone over age 60 plus who is 5 months post third dose will be a candidate for their booster. I'm going to hand it back to Dr. Wiggers just to do a very quick review of remdesivir and EvieShell.
Yeah, so just I'm seeing we're running short on time here. So as far as remdesivir, I mean, this is really the only alternate to Paxlovid for those who aren't eligible for it. The big barrier here is that this is an intravenous medication that requires 3 daily doses. So the logistics around this are quite a challenge. For our treatment, our therapeutic clinic, we're reviewing people as far east as Belleville on occasion and up into the Haliburtons. And as far as accessing this in a clinic setting, Scarborough is the only hospital that has sort of a formal infusion clinic. So we don't even have this actively at Lakeridge. So really, if the options would be referring there versus trying to coordinate through the emergency room setting. And so we are looking to bolster this and offer this through Lakeridge, but it's just not there yet. And so I generally use a slightly more stringent sort of eligibility assessment for these patients and really try to limit it to those who are severely immunocompromised or unvaccinated and at very high risk of severe COVID. And then for the next slide, it's just quickly on EvieShell, just for your awareness. So this is not treatment of COVID. This is pre-exposure prophylaxis. So passive immunization. So it's intramuscular injections of this combination of 2 monoclonal antibodies that bind to the spike protein of COVID. There's a study very recently published in the New England Journal looking at unvaccinated high-risk individuals who are either high risk of complications or high risk of exposure, a very small number of immunosuppressed patients. And it did show, despite having very small numbers of actual symptomatic COVID cases in this population, an 88% risk reduction of symptomatic infection. There was a potential signal for increased cardiac severe adverse events. And as far as there's a very small number of overall COVID cases, but as far as severe COVID cases or COVID-related deaths, these occurred exclusively in the placebo arm. So there are some concerns around this data, and in particular, the limited number of immunosuppressed individuals that are represented, despite this being the population that we're treating. But this is looking to be something that may be offered in the near future. Okay, I think we'll open it up to questions at this point.
So far we have nothing in the chat or any hand. Oh, there's a hand. Perfect. Dr. Tanias, I believe you were first.
Hello, I'm Dr. Tanias. I'm in Pickering. So the good thing is that I attended the lecture today because just yesterday or 2 days ago, I have a patient, 76 years old, diabetes type 2, past history of stroke, 3 PCI before, and he is on Xarelto and statin and cardiac medication. And he did a rapid test of COVID-19, came back positive. He didn't receive any COVID-19 vaccine, zero, because he doesn't believe in the vaccine. So he called me at 10 p.m. that he's feeling short of breath, he's feeling like he can't walk, terrible tiredness and lack of energy, and even he can't pee, he can't wake up to go to the washroom. So I did an assessment for him if he is eligibility. Actually, he's eligible, but because of the interaction of the medication, I don't think 100% he can't receive the Paxlovid. So I think maybe remdesivir infusion would be. So I called the ambulance for him because he was in very terrible condition to take him to the emergency. So what do you think?
So I mean, it sounds like the severity of illness, certainly seems to warrant that in that circumstance. I mean, as far as it sounds like quite complex interactions, and so these are potentially cases where it would make sense to refer to the therapeutics clinic. But yeah, I mean, as far as the DOAC, that is probably the biggest barrier. That there may be ways to work around that with replacements or depending on the risk. I think it's a bit too nuanced to kind of give you an exact answer here, but I think more so the severity sounded like it warranted in-person assessments.
Okay. Yeah.
So Dr. Wigger is going to take a question from the chat. So what if the EGFR is less than 30?
Yeah, so Becky did pull up a slide there, which was a table from the Ontario Renal Network, which basically gave some guidance on dosing for EGFRs less than 30. Really, the restriction to 30 plus was based on what was studied, but not really any specific concern of harm with overexposure to nirmatrelvir. The ritonavir is hepatically metabolized, so there's really no risk with that. So it's exclusively the nirmatrelvir, and higher doses than what we're giving have been studied in the initial phase 1 trials and seem to be safe. So I am offering it to people either on dialysis or under EGFRs under 30 if there's no other contraindications based on those altered dosing. In those cases, I usually will call the pharmacist and let them know I'm prescribing off-label. This is this is an unusual dose, but this is the rationale, and obviously make sure the patients are kind of aware of this approach and agreeable.
So there's 2 more questions there, then I'll jump to the next hand. But the one question was about the significance of fluvoxamine and budesonide on the referral. And that was really just so we knew if they've been started on treatment. Brad, did you want to comment on anything else?
I think it was more so at a time when we were concerned around the volumes and the ability to sort of get to people in a timely manner, and whether they were already on something effective, particularly if they were very clearly ineligible, if we were going to have to triage and not even call some of the patients at this stage. It's not such an important piece, I would say.
And then Dr. Sidke, there is a referral form. It's been sent out through the OMA and through public health. but we will have it sent out again with a referral form for the CTC clinic, which we call the COVID therapeutic clinic. I'm going to jump back into the people. Dr. Khan or Sandy Khan, your hand was up next.
Hi, thank you. I've been working in the Peterborough COVID Assessment Center, and so we've been collaborating quite closely with Lake Ridge. As we are moving into starting to provide our own scripts, I've actually been quite surprised at the lengths at which we are going to prescribe Paxlovid to certain patients with drug-drug interactions. I mean, I've seen patients where they've had to hold their anticoagulants and they've gotten bridging anticoagulation with heparin to allow for the prescription of Paxlovid. And I guess at this point, I'm feeling like I don't have a lot of direction as to when that is supposed to be indicated.
Yeah, so I mean, we're doing that early on. I'd say I haven't done. I think we probably bridged with heparin maybe 2 of the 300 or so that we've treated, I would say, and really have kind of been avoiding that more recently. I think particularly early on when it was very clear that we were really, the criteria were very restrictive and the people that we were offering to were very, the highest of the high risk. I was more inclined to find those workarounds and really try to find any way to get them the treatment. More recently, like there is some other alternatives like the lower dose of edoxaban that's a bit more pragmatic for bridging for someone who's on Xarelto, and again, a lot of the referrals now, based on the Ontario Health Guidance, they're probably not all that high risk. So, if it's more so now, as some of these complex drug interactions are coming up, I am having more of that risk-benefit discussion where, this may actually be worse to take the drug than the risk of COVID itself.
Okay, well, thank you for that. That's very helpful as we move into this next phase, and hopefully, in future webinars, there can be a little more nuanced discussion about, where we can kind of, draw the line or have more tools for having that discussion with patients.
Thanks, Sandy. The feedback is fantastic, and perhaps a case-based lesson might be useful. If you would find that useful, please let us know. So in the chat, Nell has commented that in the antiviral data, there was a downward trend of viral load in most subjects. There was, he thought there was a reported rebound of COVID positive swabs in 11% of subjects at days 10 to 14. Can you comment on that, Dr. Wiggers?
Yeah, so I mean, there definitely was. It didn't come into the actual published trial. I think it was in part of the FDA authorization, but there did seem to be this phenomenon that in some people there would be a viral rebound. And I have seen at least one case where I was fairly convinced they actually did have a symptomatic rebound as well. I think that what we don't know is, there's a few thoughts on that. One is that, they suppressed the initial virus and now it's replicating again. The other is that, the treatment may have blunted the early immune response, and with household contacts that are infected, they could have gotten an early reinfection. It probably is the former, and it is just a rebound of their own virus. What that actually means at this point is a bit hard to say. I think we likely wouldn't retreat in those cases, again, unless it's a very extenuating circumstance where someone is very immunocompromised. So it does seem to potentially be a real phenomenon, but it's this is all very new, so I can't say much more than that at this point.
Thanks. The next one is a 35-year-old with cerebral palsy who gets quite unwell with URIs, but is triple vaccinated. Just they're wondering about eligibility for this. According to guidelines, no, but Brad, can you talk about any of the nuanced parts of?
Yeah, I mean, this often comes up with asthma or COPD or chronic bronchitis and other things as well. I mean, I think it's important to kind of frame it that, once an inflammatory stimulus has started, it may, this may just be someone who's vulnerable to, reactive airways and these symptoms following any viral infection. And we don't know for sure that, an antiviral, once this has started, would actually mitigate that. So I think what more important is to ensure that they are on their appropriate maintenance puffers. And if not, then to be treating them aggressively for the the airway disease. But in general, I wouldn't be treating it in that circumstance.
So wait time between vaccines and Paxlovid after having had Paxlovid. I don't know if either one of you has seen anything on this. I haven't, so I'll defer to the two of you.
Yeah, I mean, I think it's more expert opinion. So the wait time after infection, the recommendation from NACI is 90 days after infection. Again, there's some concern or question that, if you have a milder infection and some of the immune response is blunted by receiving Paxlovid in particular, that that boosting benefit from the infection may not last as long. There's really not significant risk of harm in getting the booster sooner. It just may not be necessary. So it's difficult. I usually am saying, I would wait at least a month, maybe, somewhere between 1 and 2 months. It kind of depends on, what the landscape is as far as case rates as well. But I probably would go a little bit sooner than the 90 days for someone who receives Paxlovid.
Thanks, Dr. Wiggers. So as I'll comment on the next one, which is in previous science table releases, they talked about ethnicity. But in the most recent one, they removed ethnicity such as First Nations, Asian, Black. I guess the question is that still considered a risk factor or not?
I think as we've moved sort of a little bit away from sort of just the risk factor counting, that's not so much of an equation. I certainly was using that again when we were looking at very stringent criteria just based on the science table, and if I had an individual who was 61 and unvaccinated, and I needed to find one risk factor to feel that I was meeting the guideline criteria if I was being audited on this, and they were from a racialized community, then I would include that in the equation. So it is. I think it is still included in some form in their guidance. I think it's more of sort of a footnote in prioritizing in those populations. But so I would still factor it in, but I think with the state of the risk assessments now, it's not such a important criteria.
Thanks, Dr. Wiggers. Certainly, I think I would agree that I would add it as a risk factor. So last question, because it is 8 o'clock. So is it true that data is all pre-Omicron? And is it unpublished in vitro data that's extrapolated for Omicron, or can you speak to the authenticity of the data, Dr. Wiggers?
Yeah, so I mean, all these trials that we were referencing were certainly all pre-Omicron. There are some preprints, essentially looking in vitro as far as the efficacy, and it does seem to hold up against Omicron. It's not real world data, obviously, but yeah. So from that point of view, there was concern with the neutralization and efficacy of sotrovimab, and then that's what sort of drove that being removed from guidelines. But for Paxlovid, at least from what we've seen in vitro, it does seem to be holding up as far as efficacy.
Okay, thanks, Dr. Wiggers. And so Doran's question was answered by Dr. Ray as to the motives behind it, but certainly Dr. Ray's answered that. So the question was about eligibility widening and loosening up more so than the science table, and certainly we obviously can't speak to the MOH's motives, but I think the idea, as Dr. Ray has said, is to encourage higher risk patients to seek assessment. They often quote that this incorporates anybody who has a 5% risk of hospitalization. So that is what the background was, but I don't know, Dr. Ray, if you want to add anything more to that.
No, I think, what we saw early was that we were just worried patients weren't coming. I mean, we still see that. I had a patient admitted yesterday in hospital who was super, super high risk and had knew had a rapid positive at home and was 7 days and then started to get super sick and ended up needing to be admitted. So, I think that the messaging from the ministry was just really, we need to get people who are potentially high risk. We need to get them seen so that we can get them treated. And so getting messaging out like you might be eligible for treatment or you could be eligible. Remember, the messaging is you may be eligible for treatment, not you are eligible for treatment. So you may be eligible for treatment. So these patients, hopefully will call your office and say, I think I need the Paxlovid. I need the Paxlovid because I saw it on the news and I've got it. But at least it triggers you. They might not end up getting the Paxlovid, but at least it can trigger that interaction between their primary care physician or their primary care provider and, the patient.
Okay, I'm going to stop us all there. And again, thanks, Dr. Wiggers and Dr. Ray, for presenting. There was a question about getting access to some of this. We will try and compile it in a Word or PDF document, especially all the resources that are in the PowerPoint, and share the PowerPoint. So if we have by no means have any sort of copyright on anything, we are happy to share anything we've made. If you have any questions, Cecilia has posted COVID response at lh.ca, or if you have any treatment questions, certainly you can refer them to ctc at lh.ca, which is COVID Therapeutic Clinic, ctc at lh.ca, and we can try and get back to you to help respond, keeping in mind that the referrals are quite high now. And as you all are aware, part of the goal of this discussion is to help with some of the questions about prescribing in primary care and to take away some of the anxiety of this new drug, which has not been rolled out as we typically would have a new drug rolled out. So I want to thank you all for coming tonight. If there's any other questions, please feel free to email any of those addresses and we'll try and get back to you.
Thanks for coming, everyone. It's so nice to see a huge turnout for this. So it's important stuff, and thanks for coming.